Welcome to the Wild Physio podcast with your host, Andrew Wild. Today, I have Dr. Kim Slater on, and he's an orthopaedic surgeon specialising in arthroscopic and reconstructive surgery of the foot and ankle. Dr. Slater graduated from Sydney University Medical School in 1980. Following postgraduate training in RPA Hospital, he commenced orthopaedic surgical training, which was completed in 1988, the year I was born. He then undertook subspecialty training as a fellow in knee surgery with Dr. Mervyn Cross, who's been on the podcast, and Dr. Leo Pincheski before traveling to Seattle to undertake a fellowship in foot and ankle surgery with Dr. Sig Hansen in 1991. A huge welcome to Kim Slater. How are you?
Good morning, Andrew. Pleasure to be on the show.
Been looking forward to this for a while. We're going to dive into high ankle sprain syndesmosis injuries today.
Yes.
And obviously, recently, you've pulled up stumps. You're still consulting, but not operating anymore.
That's right, Andrew. There comes a time where you make a decision, and I've been thinking about it for a while. I've got to say it's a bit weird because I really enjoyed the operating and the interaction with patients. But I can't believe how quickly 3 decades has gone. And over that time, I've seen some very interesting cases and had some great colleagues to work with.
Plenty of more time for golf now, Kim.
Yes, my word. Got to get that hand back down, Andrew.
A few more golf trips. Love it. All right, now let's dive into high ankle sprains. So typically, what is the mechanism of injury when we're talking a high ankle sprain, and how would it be different to a normal inversion ankle sprain that you would see?
Okay, so by high ankle sprain, I take it you're referring to a syndesmosis injury.
Syndesmosis injury. We're using high ankle sprain because I do have a fair few listeners out there, the general public. So but a lot of physios, new grads, medical students, that sort of stuff. So go into as much detail as you like.
Absolutely. Well, I'm happy to call it a high ankle sprain. So just as a little background, how many ankle sprains occur in Australia each year? Well, probably 3,000 a day. And in the States, 30,000 a day. That gives you an idea of how many normal ankle sprains occur. And by that, I'm referring to an inversion injury that stresses or strains the lateral ankle complex, the AIT, the ATFL, CFL, and to a lesser extent, the posterior fibular ligament, tibiofibular ligament. So those sprains are common, and the treatment of those, as general rule, is conservative with very good results. Of those injuries, possibly 10% may have some syndesmosis injury, but that doesn't mean the whole syndesmosis. So the components of the syndesmosis, and it's important to understand the anatomy, are comprised of the anterior fibers of the distal tibiofibular ligament, the interosseous fibers or central ligaments, and the posterior fibers of the syndesmosis. And the analogy that I use with that structure is it's a little bit like a door. If all those ligaments are intact, the door remains closed. If the anterior fibers are torn, then there may be some opening anterior of the distal tibiofibular joint. If the central fibers go, it may open a little bit more, and that allows for the talus to shift a little. And if the posterior fibers go, that's a little bit like the door coming off its hinges and allows a lot more play. So the typical mechanism of injury is said to be a weight-bearing external rotation component to the foot relative to the tibia. And that results in disruption of the anterior fibers initially. There may or may not be damage to the deltoid ligament, which is a very important component in stabilizing the talus within the mortise. And then subsequently, you can get damage to the central fibers and finally the posterior fibers. Now, those ligaments can be injured in association with fractures. And just to put it in perspective, of the fractures, up to 20% of fractures will have a syndesmosis component or a high ankle sprain component. But I think in terms of today's talk, we're talking more about high ankle sprains not associated with fracture.
We'll talk about the complications after we get through this period, but yeah.
Very good. So if we're looking at a sporting or athletic population and trying to determine if someone's had a high ankle sprain, typically those patients will describe a weight-bearing external rotation injury with pain that may or may not radiate up the leg. But they don't always describe that mechanism, and it can be confusing, it can be difficult to diagnose. So on examination, the first thing that I look for when the patient is standing in front of me is swelling that extends above the level of the ankle. With a typical ankle sprain, you'll get swelling at the level of the ankle, but with a high ankle sprain, you've got a comparison between the two legs, and you can clearly see swelling that extends up above the level of the ankle. So that's the first indicator. And there are provocation tests, the squeeze test, the cotton test, external rotation test, none of which are statistically reliable, but they're helpful in determining whether or not there's a component of high ankle sprain.
And do you use all of those in your assessment to make the decision?
Yes, I do. So with the patient sitting on the end of the table and you sitting in a chair, you can hold the tibia and translate the talus laterally to see if there's any clunking. Now, in plantar flexion, there will be some clunking because the posterior aspect of the talus is narrower than the anterior aspect. So with the foot in a neutral position or a plantar position, normally there's no clunking. But in a syndesmosis or an unstable high ankle sprain, there'll be some clunking in some cases, not all cases, depending on the degree of instability. Now, why do we do all these tests? Why is it important to determine if there's a high ankle sprain? Because we've got to decide if there's instability or stability, and that will govern our treatment. So that's the sort of initial assessment of whether or not there's a suspicion of a high ankle sprain, and then you probably want to talk about investigations.
Yeah, exactly. Yeah. What investigations are you using, imaging, etc., to make a determination where to go with rehab and management?
Certainly. In all these cases, if the patient describes pain to the extent that they were unable to bear weight, then you've got to suspect a fracture or a talar lesion or a high ankle sprain. So a weight bearing, if they can take weight, plain X-ray is the first step. If they're in such pain they can't take weight, obviously you get a non-weight bearing plain X-ray with mortise views, lateral views, oblique views. That doesn't always show displacement or widening of the syndesmosis, even when there has been partial disruption of the fibers. So if you're suspicious clinically and the X-ray is normal, the preferred investigation would be an MRI scan. Now that's very sensitive in terms of identifying the components of the syndesmosis, but it's not predictive of the need for fixation, and it's not reliable in terms of assessing stability of the distal tibio-fibular joint. In other words, you can have an MRI scan that shows disruption of the anterior and central fibers and intact posterior fibers. But if the patient has significant swelling above the level of the ankle and clinical instability, where there's doubt in those cases, then I'd proceed to arthroscopy. And occasionally I'll say, oh, this patient definitely will need fixation with a tightrope. And I get in there and there's no significant widening between the talus and the distal tibia and fibula. So the MRI scan is very helpful, but it's not predictive of the need for fixation. If you've got the posterior fibers intact and the deltoid is intact, in most cases, these patients can be managed in a brace or a boot with a period of restricted weight bearing and then physiotherapy.
And how long typically are you putting these people into a boot, and is it non-weight bearing early on?
Yeah, Depending on the patient's level of pain and the degree of disruption of the fibers, if they've got, say, a grade 2 where the anterior and central fibers are disrupted but posterior fibers are intact, I'll typically keep those patients in a boot, non-weight bearing, for 2 to 3 weeks, then protected weight bearing with the boot off at 4 weeks, aiming for active range, assisted active strengthening. And as a rule, it takes about 8 to 10 weeks for those patients to resume full training and playing. Whereas you might, with a grade 3 ankle sprain, for example, it may take 4 to 6 weeks. So typically high ankle sprains lead to a delay in recovery and a delay in return to sport. And that's why it's important to identify them.
Yeah. And when it comes to surgical indications, so you've mentioned some of them already. So what are some of the surgical indications that you would find on assessment combined with follow-up, combined with imaging, where you would definitely go down that route of going for the tightrope?
Absolutely. The distal tibiofibular space on the plain X-ray can be helpful. If that's greater than 6 millimeters or 5.5 millimeters, which is considered in the literature the upper limit of normal, I'd proceed to an MRI scan if I'm thinking about surgery. If that's supportive, then I'd perform an arthroscopy, and of course taking into account the deltoid ligament. If the deltoid's ruptured, then it's highly likely that high ankle sprain is going to be unstable. You don't necessarily need to repair the deltoid, but we need to perform some sort of fixation of the distal syndesmosis, either with a screw, which I used to use, but these days more commonly with a tightrope, which is a very reliable fixation device that has the advantage that you can get them moving a little bit earlier. Typically, I'll allow those patients to weight bear after 3 weeks, whereas a screw, it's 8 weeks. And you don't have to take the device out, which has had the added advantage of early mobilisation without the need for secondary procedure. On the MRI scan, if I'm doubtful about the degree of instability, then I'll scope those patients. And that's the decisive factor about whether or not they need fixation. Now, if we look at the distal tibiofibular recess, a probe which is 2 millimeters in diameter in a normal joint can just be passed up between the tibia and the fibula. The tip of that probe has a 90-degree angle of about 4.5 millimeters. Now, if I can put the probe up and turn that sideways, and we've got a gap of 4.5 mils, then I'll fix them with a tightrope. In between, say, 4 mils and 2 mils is a little bit of a grey area. So if the patient has any form of generalized laxity and the deltoid's intact, I'd probably leave something between 2 and 4 mils without fixation. But greater than 4 mils, and if you can pass the scope up between tibia and fibula, you can see where the disruption is. These patients do very well with fixation. Now, why do we fix them? Because we hear about some patients who can do well without fixation. I think in the athletic population, the demands are much greater, and it's risky with patients who display mechanical instability in that setting of an injury to try and treat those without surgery if the posterior fibers are disrupted or the distal tibiofibular joint is widening significantly.
If it has been missed, and say, for instance, 6 months' time, they come to you and they've had a complete disruption.
Yes.
What can happen during those 6 months, and what would you typically look at doing?
The literature says that an unstable high ankle sprain can lead to degenerative changes. Now, if we backtrack a little bit and look at the MRI scan findings, approximately 17 to 20% will have an articular cartilage lesion, whether it be an ulcer or a cartilage flap or a true talodome lesion. So even if they don't have articular cartilage damage, the thought is that some of these patients, although they may not be able to function terribly well, will develop degenerative changes earlier than if they have fixation. So there are some very good studies to support that notion that stabilization of an unstable high ankle sprain with a tightrope can be preventive in terms of degenerative change.
And then at that 6-month mark,
Oh, I
then
beg
you
your
would,
pardon. Yes.
then you would.
So up to the latest I've operated on someone with syndesmosis or a high ankle sprain instability is 5 months. That was a state of origin player. And what he complained of was lack of power and lack of control. So he was unable to accelerate or decelerate confidently without pain. And his investigations in those days, MRI wasn't available, but arthroscopy clearly showed his instability, and with screw fixation, he recovered very well. So typically the patients will complain of activity-related pain, some swelling with activity, a failure of acceleration, deceleration, pivoting, control, and power. So beyond 6 months, there are reports in the literature of various forms of reconstruction of the syndesmosis. Touch wood, I've not had to perform those procedures, but they entail harvesting either gracilis or semitendinosus and rerouting it through tibia and fibula to rebuild the syndesmosis.
And when we're talking about the surgical options that we have with the screw versus the tightrope,
Yes.
When did the tightrope become common, and what are some of the advantages and disadvantages of both?
Okay. Up until approximately 2000, screws were commonly used, and there were combinations of screws. People tried a 3.5 screw or 4.5 screw, and then they talk about engaging 3 cortices or 4 cortices, which means going right through the tibia, both cortices fibula, both cortices tibia. That's a very stable construct. In the setting of ankle fractures, the problem with that was that CT scans subsequently showed a very high percentage, up to 30% of those were malreduced, leading to degenerative change. So even experienced surgeons who thought that they had the screws in the right position were finding on CT scans that they weren't in the right position. Now, some studies subsequently showed that removal of the screws at 8 weeks allowed the fibula to sit back in its correct position. So perhaps no harm was done, but there was a trend in the States to leave those screws in. And as you can imagine, there was a high incidence of stress fracture or stress fatigue fractures in the fixation devices. And I've seen patients who've had 2 screws put in, returned to high-level sport, rugby league, and busted the screws and then had pain. Now that causes a big problem, because you've got irritation between tibia and fibula with screws that are inaccessible. You can get the head out, but to get the rest out, you cause a lot more damage. Despite that, the trend in America when screws were used was to leave them in and let them bust, even in NFL players and basketballers at a high level. So I think it was an Irishman that first developed the tightrope, and it was a great advent in that we could allow a little bit of play in the distal tibiofibular joint because the fiber wire was flexible, which meant that the malreduction was not as common when CT scans were performed on these patients. The added advantage is that the device didn't need to be taken out. Now, having said that, early on, a lot of people were putting these things in, and basically you pull it through and flip a little button on the medial side, then pull it back and tie it up. So there were problems with the buttons that weren't completely seated, and also with the knots that were causing irritation on the lateral side. A lot of those problems have been circumvented by making a little incision medially and making sure that that button is seated on the cortex so the patients don't get irritation. And laterally, the fixation wires now, when pulled down and snugged down, don't require to be knotted. So they're much more low profile, and you don't tend to get the stitch abscesses and painful lumps that were occurring before. As far as screws, I think the trend is away from screws, although some people still use them. It's a reliable method, but in my hands, if I use a screw, I'll take it out at 8 weeks and keep the patient non-weight bearing up to 8 weeks. So you get some downside in terms of wasting, stiffness, delayed return of range if the patient's non-weight bearing for 8 weeks. And that's why I think the tightrope is a much better fixation device. Now, in elite athletes, there are a lot of surgeons who use 2 tightropes. I think that's reasonable, but given the strength and the studies in the lab of these devices, I think 1 is fine.
When they're using 2, are they using one that's more distal and proximal to each other?
There's no point going any more proximal than 5 centimeters up from the ankle joint. So as a rule, the first one will be inserted about 15 mils above the level of the ankle joint, and the second one the same height again above that one. So 3 centimeters from the ankle joint.
So you're just doubling up, really.
Yeah, I suppose you're covering your bases and taking out insurance. But having said that, I've not been aware in my own hands of any devices failing.
Yep, that was my next question, actually. And what is the tightrope, just for the listeners, what is the tightrope actually made of?
It's made of a very strong, non-absorbable thing called fiber wire, which is like an extremely strong suture, which is inert. It doesn't get absorbed. It remains in the body and it incorporates into the bone and provides ongoing stability.
Yeah. What I've read, it's a braided polyethylene core, would you say?
Correct. Yes.
Yeah, it's fascinating because 20 years ago was kind of when the tightrope was coming in, but prior to that, it was effectively just the screws that you would use. And for the people back, say, 60, 70 years ago that had a high ankle sprain or syndesmotic injury that was a complete rupture, how would their ankle have typically presented when they were, say, 60, 70, 80 years of age?
Yeah. If we come back a little, oftentimes we'll see in elite footy players from, for example, Tonga, Samoa, Fiji, who haven't had access to sports medicine doctors, physios, and surgeons. They may have had a high ankle sprain, and on their plain X-ray, they may present for some other reason. But on their plain X-ray, they'll have very significant calcification in the distal tibio-fibular area, and you've probably seen this on X-rays. That would indicate to me that they've had a significant high ankle sprain and nature has attempted to stabilise the ankle. But over time, because there's increased play, these patients tend to present, particularly if the deltoid was injured, and you can generally tell that from plain X-rays. They've got lateral shift of the talus, narrowing of the lateral aspect of the ankle joint, and degenerative change. So in other words, valgus ankle arthritis. Yep. That's the answer to your question over 50 to 60 years. And this is why we fairly aggressively fix them if they're unstable, and certainly are suspicious of these injuries in a patient who presents with the sort of picture that we described earlier on.
And when using the tightrope procedure, how long are athletes typically taking to get back to sport at a decent level, you know?
Yeah, if we look at the NBL players and NFL players, there are reports of them getting back at 4 weeks. Now, I think that's asking a lot of the tightrope and a lot of nature, because nature doesn't heal that syndesmotic structure that rapidly. So in my hands, I say to the patients, we're looking at roughly 3 months, but it may be a little earlier. You can shorten it maybe a couple of weeks, but not much more. Now, if as a surgeon, you say to the patient, I'll have you back at 5 or 6 weeks, and it's actually 8 or 10 weeks, then everyone's twisted out of shape. The trainers, the coaches, the physios, and everyone's copping flack and the patient's unhappy. So a practical way of dealing with it, in my view, is to say, look, on average, it's going to take 3 months. Now, if it's 10 weeks, everyone's happy. If it's 8 weeks, everyone's absolutely thrilled. I should add here that we just got to be a little bit careful assessing the results of these. I saw a patient who was a first level rugby league player that I'd seen previously as a patient, and he had a tightrope and he was back playing State of Origin at 3 weeks. And I thought, what the hell? Am I missing something here? And I went and had a look at his MRI scans, and in my opinion, he didn't need a tightrope. So on the surface, it looks like this is great. The tightrope got him back at 3 weeks. But you've got to take it with a grain of salt, because in my view, he didn't need a tightrope. Therefore, he had a procedure that's unnecessary. And that's why he got back at 3 weeks. He probably would have got back at 2.5 weeks if he didn't have a tightrope. And I'm not being critical there. I'm just saying you've got to take it with a grain of salt when you read these stories that, oh, so-and-so had a tightrope and got back at 3 weeks.
And if you went for the screw option, which sounds like it's not being used very often now, how long would it typically be the return to sport after a screw?
3 to 3.5 months. So the screw would come out at 8 weeks. In my hands, I think it's safer to remove the screw than leave it and let it break. Then you don't have the issues of a broken screw and pain to deal with later. So at 8 weeks, the screw comes out, the patient then starts mobilizing. And as a rule, at 3 months, they're back to full training.
Yep.
So a little bit slower than the tightrope. They certainly regain range much better, much quicker with the tightrope than with the screw.
Yeah, and anecdotally, I've seen that. That's definitely something that is a big change between the tightrope and the screw. Early on in my career, I saw a couple of screws, and they're just they're slower and they're stiffer.
Very slow to regain dorsiflexion. Yeah. And for elite athletes and dancers in particular, range is everything. After these injuries, you'll often find the last couple of centimetres of knee to wall are very slow to come back. But as long as the patient has functional range, they'll be able to return to unrestricted sport.
And what are some of the other complications you often find when people have either a high ankle sprain or even just your normal inversion sprain, when we're talking fractures and other issues that can go around the ankle? What are some of the things that people should be looking out for, either on assessment or on imaging?
I think if we talk about the run-of-the-mill sprains, if the patient is able to bear weight initially, then it's highly unlikely that they have a fracture or a talar dome lesion. If the patient describes inability to bear weight, either for a day or a couple of days or a week or so because of pain, then they've got a fracture or a talar dome lesion until proven otherwise. And those patients, I think, should have an MRI scan. So the answer to your question is missed injuries, typically talar dome injuries, can have a significant deleterious sort of outcome if they're left alone. And sometimes on a plain X-ray, they won't show. That's why I say they need an MRI scan. So a plain X-ray of a talar dome lesion, quite often in a sporting sense, will look completely normal. But at 6 weeks, you'll start to see some lysis or darkening on the corner of the talar dome. Subsequent investigations will show lysis and instability of the lesion. Now, the earlier that they're dealt with arthroscopically, the better. If you get them in the first 4 to 6 weeks, and so they should have an MRI scan. As far as other complications, we do see the so-called fracture disease. If patients are managed non-operatively with a fracture, they get stiffness, swelling, reduced range of motion, and therefore delayed recovery, return to sport. Operative complications include infections, blood clots, and so on. And we mentioned malreduction. That's less likely with a tightrope than with a screw. Yep.
And one last question: the Mesa nerve, is that how you say it? Fracture.
Yes. Mesa nerve.
How often have you seen those? Because I've never seen one in my career, and I've been in the game for 11 years now. How often did you see one of those, and what would you typically do with that? And also just describe the actual Mesa nerve fracture.
Okay, the Mesa nerve injury describes it's an injury that starts at the ankle with weight-bearing external rotation like a high ankle sprain, but the sequential damage to the components are Possibly the deltoid disrupts first as the ankle turns out. Then the anterior fibers of the syndesmosis go, then the central fibers, then the posterior fibers, but the foot continues to rotate outward and the force is transmitted up through the fibula. Now, a spiral force is a very powerful one, and the fibula can fracture at any level from the ankle joint right up to the knee. So a Mason nerve describes an injury where the syndesmosis is disrupted, but the fracture to the fibula occurs very high up, possibly 4 or 5 centimeters from the fibula head. The significance of that fracture, and if you palpate the patient's leg and they'll feel tender up there and you need to get an x-ray, because otherwise you'll send the patient for an x-ray and they'll x-ray the ankle, but they'll miss the fibula, proximal fibula fracture. So the significance of that injury, it's a spiral. It indicates that the entire syndesmotic complex has been torn, and there's a very high incidence of instability at the ankle in those cases. So it's important to make the diagnosis. Now, fixation, we don't tend to fix that fracture. It's tiger country up there. There's the common peroneal nerve passes around the fibula at that level. That's not the reason that we don't want to interfere there, but it's considered unnecessary. That fracture will heal quite satisfactorily because it's a long spiral fracture. There's a big surface area for healing. But fixation distally is important if there's instability. So the key is, if you see that spiral fracture in the proximal fibula, think what's happening downstream in the syndesmosis, because it's highly it's definite that all those ligaments have ruptured and the ankle is going to be unstable.
Yeah, and medial malleolar fracture with that, is that common?
Yeah, so either the deltoid ruptures or the medial malleolus is avulsed, and I'll show on an x-ray, and you may see some medial joint space widening on the plain x-ray. The other thing, you asked me how often I'd seen those. Probably see a Mason nerve once or twice a year.
Yep.
Yeah, but that's the nature of the practice, that I was doing foot and ankle surgery. So I wouldn't say it's common, and in the literature they say it's less than 0.5% of a syndesmosis injuries.
Great points, Kim. Any final words or words of wisdom, advice for the young listeners out there that are either young physios, medical students, young students in any sort of health profession? Got any wise words?
I think that one of the trends, Andrew, that I've seen over the years is, and I can be a little critical of our profession in this, is the tendency to not assess the patient with a careful history and examination and go straight to an MRI scan, read the report and treat the report. So Merv Cross taught me this in my sports medicine and training fellowship. Assessment of the patient clinically and historically there's no substitute. Oftentimes you can make the diagnosis by listening to the patient, by carefully assessing them, and then the investigations support your clinical opinions or your clinical findings. And I think it'd be a shame if we lost that art of clinical assessment. I've seen patients for second opinions and the reports have been incorrect. So I tend not to read the reports. In most cases, they're correct, but there may be things that are missed or inaccurate, and the radiologist doesn't have the luxury of assessing the patient. They just look at the films. So my only advice would be sit down with the patient, try and be a detective about what the mechanism of injury was. Do a careful clinical examination, and with the knowledge of the underlying anatomy, we can generally work out what's going on and what's happened. That'll guide your investigations. And then sit down and look at the MRI scan with the patient. Do your diagrams, explain things, and it all makes sense in most cases.
Yeah. Great advice. It's similar to what Merv said when I asked him a similar question. The examination is key, and be thorough and continue to delve deeper. And it's going to often give you the diagnosis by just listening to the patient.
Well, the other thing is, Andrew, that the patients appreciate that.
Yeah.
They understand that you're keen to establish what's going on. You're interested in them and their management, and it gives them security, so that if things go wrong, at least you've got a good relationship with the patient. Whereas if you just look at the report and say, don't even ask them to take their shoes off and say, mate, you need an operation, and things go wrong, you're not off to a good start.
Yeah, agreed. Thanks so much for your time, Kim. Where can the listeners find you if they want to either consult with you, because you're still doing a little bit of consulting, or even if they've just got a question about something, even if it's a medical student or someone that's, starting physio or something like that?
I'm not attending the Mater Clinic rooms, but they can certainly access me. There's an email access through those rooms. So North Sydney Orthopaedic and Sports Medicine Centre, which is at the Mater Clinic, North Sydney. And they'd be welcome to send any questions or comments, and I'm happy to respond, Andrew.
Great. Well, thanks again. This podcast is live on Spotify, Apple Podcasts, Google Podcasts, and all the channels. Thanks again, Kim. We'll have to catch up soon over a game of golf and a beer.
Definitely. When the weather improves, Andrew, my treat. Thank you very much for having me. All the best.
Absolute pleasure. Thanks again. And as usual, stay strong.